So we're on to poster presentation 7 now, and we're so happy and excited to hear about optional vaccines among 3 to 6-year-old children in an urban setting in Vellore, India. Welcome, and you may begin your presentation.
Thank you so much, ma'am, for that. Good afternoon, everybody. Today, I'll be presenting on our study on the coverage of optional vaccines in 3 to 6-year-olds in an urban setting in Vellore, India. Next slide, please. Immunization is a process by which a person is made immune or resistant to an infectious disease by the administration of a vaccine. A vaccine is a biological preparation which contains an agent that resembles a disease-causing microorganism, and it is typically made from a weak microbe, its toxins, or one of its surface proteins. This improves the immunity to a particular disease. In India, vaccines can be classified into two: essential vaccines and optional vaccines. Essential vaccines are those which are included in the National Universal Immunization Programme, and under this program, no child can be denied immunization. The vaccines include BCG, polio, diphtheria, pertussis, tetanus, measles, tetanus toxoid, hepatitis B, Haemophilus influenza B, and in few states, Japanese encephalitis. The optional vaccines, on the other hand, are not included in the National Immunization Programme and are given on an optional basis. However, they prevent common causes of morbidity and mortality in the Indian population. Almost all the optional vaccines prevent disease which are highly prevalent in our setting, and vaccine preventable diseases form a major bulk of diseases in children, and as you can see, is a significant cause of morbidity and mortality. Next slide, please. Next slide, please. So as you can see in this table, optional vaccines cover diseases which may form a major bulk of morbidity and morbidity in India. No study has been done before to analyze the coverage of optional vaccines in the study area. For our study, we included hepatitis A vaccine, pneumococcal vaccine, measles, mumps, rubella vaccine, rabies vaccine, seasonal influenza vaccine, typhoid vaccine, and varicella vaccine. The reasons for choosing these particular vaccines were the diseases caused were highly prevalent in our area, they were cost effective, they are given around the similar age group, and they're not included in the state immunization schedule. Despite the proven efficacy and safety, the uptake of optional vaccines are very less since its introduction. The National Family Health Survey studies have showed a drop in the vaccination coverage in India, as you can see from this graph. And factors affecting vaccine uptake have to be studied. Next slide, please. So the objective of our study was to estimate the coverage of select optional vaccines among children in the age group of 3 to 6 years in an urban setting of Vellore, and to explore the barriers and facilitators towards the uptake of these vaccines among caregivers to children of the same age group. Next slide. Our study was a community-based cross-sectional study, which was done in the urban population of Vellore town, including wards 16 to 60 situated south of the river Palar. Children in the age group of 3 to 6 years were included, and everybody was included in the particular age group. There was no exclusion criteria. Period of study was 2 weeks, and sample size were 210 households based on a prevalence of 50% from another study. Next slide, please. In this study, we chose the 30 into 7 cluster sampling as recommended by the World Health Organization for vaccine coverage studies. Wards were taken as clusters. So 30 clusters were chosen from 45 wards using probability proportional to size. And from each, one street was chosen randomly. And from each street, the first 7 households with children in the age group of 3 to 6 years were identified. All the children in that particular household which fit into the age group were included. If the required number was not achieved in the selected street, the next street on the list was included and continued till the sample size was achieved. Written informed consent was taken from the primary caregiver. The primary caregiver was interviewed. Data entry was done, analyzed, and presented. Next slide, please. So the picture I've put here is a map of Vellore which shows all the wards. The ones marked in purple are the 30 out of the 45 wards which were included in our study. Our study tool was a semi-structured, pilot-tested, interview-based questionnaire. Data entry was using Epidata version 3.1 and analysis was done by SPSS version 25. Univariate analysis was done. Vaccine coverage was represented as a proportion. Continuous variables were measured as central tendencies, and categorical variables as frequency and percentage. Bivariate analysis was done using the Pearson's chi-square test, and multivariate analysis using the logistic regression analysis. Next slide, please. So, in our study, a total of 220 children from 210 households were included. The socio-demographic data of our study population were as follows. Among the 210 primary caregivers interviewed, most of them were women in the age group of 26 to 30 years, and they were mothers. Most of them were literate, had secondary school education, and were employed as semi-skilled laborers. Among the 210 households interviewed, most of them belonged to Hindu religion. They were of backward caste and they were of lower middle socio-economic status as per the BG Prasad classification. And out of the 220 children that were interviewed, most of them were first born, they were females, they were between 3 and 4 years of age, and they had immunization cards. So the individual vaccine coverage had a wide range. It ranged from 0.9% for anti-rabies vaccine to 46.8% for measles, mumps, and rubella vaccine. And the total vaccine coverage was 54%. 46% of our population did not receive any optional vaccine. Next slide, please. Higher socioeconomic status, higher maternal education, health professionals' advice, access of the caregiver to smartphones, and birth in a private hospital were found to be predictors of good vaccine uptake. Next slide, please. The barriers to vaccine coverage observed were lack of knowledge, cost of the vaccine, non-availability, and false knowledge of the apparent inefficacy of the vaccine. Next slide. So, to conclude, the coverage of vaccines ranged from 0.9% for anti-rabies vaccine to 46.8% for the measles, mumps, and rubella vaccine. And the awareness were as follows. This also ranged from 16.8% from anti-rabies vaccine to 55.9% and 56.4% for the varicella vaccine. Next slide, please. So the factors associated with the vaccine uptake were as follows. High socioeconomic status, caregivers' education, health professionals' advice, and smartphone use. And the barriers were lack of awareness, heard that it was not very efficient, relatively expensive, and lack of availability. The strength of our study was that we used a two-stage cluster random sampling with probability proportional to size. And the limitations were for the ease of access, wards south of the river Palar were chosen. Some of the houses in the streets were locked, maybe because both the parents were involved in work and they were the breadwinners of the family. There were people without vaccination cards, and therefore we had to rely on reported information. And the doses of each vaccine were always not reported or documented correctly. Next slide, please. So, to conclude, our recommendations from this study are to encourage medical practitioners and other healthcare providers to give counseling regarding the uptake of optional vaccines. Since mobile phone is an important source for dissemination of health education, it must be utilized to create more awareness of public and to educate the public and the primary caregiver regarding optional vaccines. To facilitate this, at the end of our interview with a primary caregiver, we had distributed pamphlets to all the study population so that they would be encouraged to take these optional vaccines. Thank you.
What a wonderful presentation. Thank you so much. We really appreciate you being here today. I know that you are presenting very far away from where I'm speaking in Washington, D.C. But how wonderful through the power of this technology, we're able to connect with you and learn about your really important work. Obviously, this is a very important subject, particularly considering, what we've been going through as a global entity over the past few years with COVID. And you really, really did illustrate like that connection between factors such as, someone's socioeconomic status and their engagement with vaccines. So look forward to hearing more about your work in the future.
Thank you, ma'am.
I don't know if anyone had a chance to put any questions in the chat for you, but if you go over to the presenter attendee booth, you can maybe engage with some folks.
Okay,
And
sure.
all the best to you. Yes, look forward
Thank
to
you.
staying in touch.
Thank you, ma'am.
Bye.
Thank you. Bye.
Bye.